Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Yemi Famuyiwa, fertility specialist. Today's Kevin MD article is Why Carrier Screening Results Are Complex. Yemi, welcome back to the show.
Thank you so much, Kevin. A pleasure to be here.
I have to admit, when I read your article, I actually had to do a little bit of research and understanding myself because a lot of the things that you brought up, I haven't encountered since medical school and
I
residency.
know, right?
Now, give us a little bit of context about why you decided to write the article and then talk about the article itself.
Well, because nowadays everybody's getting genetically screened,
Yeah.
and the panel that we used to use way back when was 23 genes. Then it came up to 1100 and something genes, then 250. Now we're testing for 787 plus genes to get carrier status. And not only that, because the technology has rapidly advanced, what we used to think of as, oh, let's say cystic fibrosis, if you're either positive or you're negative, right? It was black and white. Now we know that not so fast. It's very nuanced and is creating a lot of anxiety and for our patients and a lot of complexity in counseling them about the results.
Now, are you talking about these commercial genetic screening tests that you could get on the internet or you see commercials for, or are these tests that physicians are prescribing?
Okay, so I don't even go into the realm of commercial ones. These are the ones that we use in clinical setting. Yes.
All right. So you're a fertility specialist. So how do
Correct.
you typically use these screening tests in your
Mhm,
practice?
mhm. So because we now know that just because in the old days we used to say, well, if you were Ashkenazi Jew, you test for this. If you were African American, you test for sickle cell. We now know that there's such a wide variability and society is so intermingled that that doesn't hold anymore. So you would surprisingly find something that might be associated, let's say, in a Caucasian population. And, I had a patient, Nigerian, who their kids came up with a disease process. She had gotten IVF done out of the country that I hadn't even heard of.
Mm.
And I had to go look it up. I'm like, what? You're not supposed to have this? So we're seeing that in real life. Or I got a patient whose husband's screening came back with a silent carrier for SNM1. And I'm like, what? What is that? How do I guide the patient? Because the patient will say, well, what does this mean? What do I do with this results? So I usually recommend genetic carrier screening for both couples for that reason, because you just don't want to be, number one, blindsided with something you were not expecting at all. And I think in 2025, that's almost inexcusable to have that happen.
So when you see a couple or patient for fertility,
Correct.
you routinely order these tests that test for several hundred
We
genetically.
routinely counsel them
Okay.
and I provide the information and I tell them these are the recommendations from the American College of
Okay.
OBGYN that, screening is recommended, but I don't make it a do or die,
Mm.
right? I insist that you get the counseling and you as an adult, you have the right to make your own decision.
Hmm.
But the question is, have you been given all the right information to make the appropriate decision, right? I mean, go ahead.
Yeah, and of those tests that's being tested for, just give us examples of which is the ones that would have the highest impact or the biggest
Yeah, yeah.
repercussions for a couple.
Oh, absolutely. For instance, we talked about cystic
Yeah,
fibrosis, right?
yeah.
It's an autosomal recessive, meaning that if you have two of the defective genes, you have it. If you have just one, you're in the clear. Well, we're finding out that you may be in the clear for the lung manifestations, but if you are a carrier, it can still show up in bad ways. For instance, in gentlemen who have azoospermia, no sperm, and they get sequenced and found out that they're a carrier for cystic fibrosis. The problem with the cystic fibrosis carrier status, it's not black and white
Yeah.
because it could manifest in very mild forms or also in severe forms. The very mild stage, they have no symptoms. The moderate stage, they have blockage of the vas deferens, no sperm coming out. And in some of them, they have a severe state where they may start to have some of the pulmonary effects. And it all depends on which gene, how much of it is affected, and what is the what I think of as the dimmer switch. So in addition to have the 5T defect that you have in your protein factory making the CTFR protein, there's also a dimmer, meaning how severe it can be. So you got to get the full sequence in order to be able to appropriately counsel them about their risks. The other one is, say, von Willebrand's disease. We used to think, okay, fine, X-linked disease, it'll show up in the men, right? But women now have been found to have, if they're a carrier, they may have bleeding problems during pregnancy. So they may need to be watched a little closer. Now, the one that's going to shock everyone is sickle cell, right? Sickle cell is very prevalent where I come from, right? I'm originally from Nigeria. To the point, it was so bad that in Nigeria, to get a marriage certificate, you need to go show them your sickle cell status, right? And people were counseled about that. And they said, well, if you're AS, if you're, sickle trait, you're okay. Not so fast, because some of the people who have sickle cell trait may actually have renal necrosis and they may be subject to sudden collapse during exercising. So there's slightly abnormal things that may happen. Another one is G6PD deficiency. That's X-linked. So we thought, okay, fine, X-linked. If the man gets the inherited X, they get it, right? Because they only have one X. However, the women who are carriers may also have problems, right? Some of them, if they're exposed to certain medications, may have sudden hemolysis, right? They may, if they eat like fava beans is the one most people are familiar with, they may also go into a crisis with it. So very subtle changes from, you're affected to you're not affected to you may not be affected, but there's a nuance there. And here's the things you need to watch out for so you don't fall victim to some of these things.
So you just mentioned 4 diseases,
Yeah,
each with
exactly.
dozens of permutations, and
Exactly.
you screen for hundreds of these diseases. So there could be
Yes.
literally thousands of possibilities. So
Ah,
how can patients make sense of this, and how do you guide patients through all
exactly.
this?
So, yes, so you just hit on the number one conundrum that more sometimes may not be better. I mean, there some companies out there saying we could screen up to 17 or 15, thousand genes or whatever it is. I think going forward, this is where AI is going to come because you're right. When we do this many number of genes, we're going to see some changes that we haven't even heard of yet, right? So variants of undetermined significance, like what does this defect that we just found out mean? Is there associated disease state with it, or is this something we should be worried about? So those are part of the problem that we haven't fully solved. However, I think going forward, some of these things is going to be fed into the AI machinery coming out, and maybe the algorithm will be able to sort it out a little better for us going forward. There's also a tendency in some, although the American Society of Reproductive Medicine has come out and said there's no room for it in clinical practice, but you could also look at polygenic screen risk scoring, right? To see, is this child going to be at risk for disease XYZ, right? The problem with that is that we could start to use it in a wrong way, right? If it's for a specific disease that could potentially be life-threatening, yes, it may have some use. But if we're just doing it because we want to create a superhuman, if you will, then you run into ethical issues. But I agree with you that just as the field has exploded and given us a lot of actionable data, it has also exploded the need for proper genetic counseling and also the complexity of the counseling needed to guide patients. The long and short answer for what you asked me is if I come up with some of these things that are not your simple cut and dried results, I usually get a detailed genetic counseling session for the patient to help them manage that information overload, if you will.
And how available are genetic counselors? Is that a
Yeah,
relatively specialized field? Like I know in my area,
yeah.
sometimes it's a little bit difficult to get that. And how often does that happen where you would have to refer patients over to a
Not
genetic
very
counselor?
often.
Yeah.
Yeah, not very often. I'm seeing a few here and there. So not very often. Although the companies that do this genetic, that offer the multiple gene panel, the ones we use especially, they already have a built-in genetic counseling company with their platform. So when the patient gets a result that flashes something is off, they automatically get a follow-up phone call from the genetic counseling company that says, hey, this is what we saw, here are your risks, yada, yada, yada. And if they want more detailed counseling, or maybe a close family member wants to know, well, what does that have to do with me? Then that's when you go with specific genetic counselors that might need that. So to answer your questions, they are not readily common, but it depends on which company does the testing. A lot of these companies do have in-house counselors that we have availability to.
So I know that we're not referring to commercial genetic testing, people that can just order it offline. But those are ubiquitous. I see ads for those all the time, right?
Yes,
So
yes,
and
yes,
then before talking to you, I didn't get the sense of the amount of nuance and
yes,
repercussions that could arise from them. Do you
yes,
feel that patients aren't getting the proper education when they're seeing these commercials or sometimes
yes,
clicking on some
yes,
link online about the possible permutations and
yes,
everything that could happen from these
yeah.
over-the-counter genetic tests?
I would caution extreme caution. Don't do it as sort of a cocktail, curiosity. And by the way, the biggest company that used to do that, 23andMe, went out of business. Was it this year, or last year? So they went out of business.
Hmm.
The difficulty with doing a test without a physician ordering it and being able to say, okay, here's the result, this is the next step, is that you're going to send this thing, they may or may not offer you any counseling. So now what you have done is you have bought a whole boatload of anxiety that
Yeah.
I just can't think that would be very helpful for patients. So my encouragement is, if you're really curious, then talk to your OBGYN, talk to your internist, see a reproductive specialist. But I would go with the ones that we order medical based, because then I know how to triage it.
You mentioned about the possibility of AI sifting through
Correct.
all the results and giving their interpretations.
Absolutely.
As far
Yeah.
as you know, are there any tools or anything down the pipeline that uses that?
There are some companies out there who it's still, I think, in the very, very early stages,
Hmm.
that are working on it, but it hasn't been 100% widely accepted yet. I mean, it's, sort of like, I don't know if you recall when CRISPR first came out,
Hmm.
and this one scientist in China genetically modified some genes in twins, right? And everybody was aghast, like, where was the medical necessity and why would you do such a thing? And he suffered some penalties for that. But fast forward, now that we've heard about it, we know about it, we've adopted it better. And now they're saying, well, maybe there's some utility for it in certain disease processes that, for instance, sickle cell, that has a very specific modification to a gene, that can you fix that defect, that correct that genetic material at the DNA level so that that person can live a normal lifespan,
Hmm.
right? So those things are coming out. And what's fascinating is we're talking about DNA here, right? So your DNA gets translated to an RNA, right? And then your RNA is the footprint, the blueprint that makes the protein, right? So now not only can you edit the DNA, some people have been talking about editing the RNA itself.
Mm.
And now you're going one step forward. You could edit the protein itself. So you could edit the transcriptome and we're going into proteomics and metabolomics. That may be where I'm sure when you and I sit down 5 years from now, God willing, we're going to have a whole different conversation because the technology is going to be much, much advanced. And the way AI is working, I was reading the other book today by I think he's the head of AI for Microsoft, and he wrote the book called Open Wave, if you've ever heard that book.
Mm-hmm.
The amount of data that this thing can handle and spit back out at us is just phenomenal. So I have no doubt whatsoever that AI is going to be able to interpret this. But the utility, I think, for AI, here's where I'm curious. It'll look at not just the genome, right, the DNA material. It'll look at the transcriptome, the RNA. It'll look at the protein. It will also look at the metabolites, right, the metabolome. It will correlate it with the exposome. What are you being exposed to? Because we know just because you have a gene doesn't mean it's going to come out. It's also sometimes dependent on your exposome, right? Because that could give you post-translational modifications like histone modification, methylation, that changes the output, right? So the DNA is there, it's not changed, not mutated. The RNA comes out unchanged, unmutated, but then you have exposure that manipulates how they interpret the final product. That is where I think AI is going to take off.
We're talking to Yemi Famuyiwa, fertility specialist. Today's KevinMD article is Why Carrier Screening Results Are Complex. Yemi, let's end with some take-home messages that you want to leave with the KevinMD audience.
So take-home message. It's not black and white. It's not you're a carrier, you're dominant, you're recessive. It's a little bit nuanced. And when you get this test, you need to be able to talk to someone who can break down the nuance. And we also have something called residual risk. Just because you came out negative doesn't mean you're free and clear. It may simply mean that the testing that we have today is not capable of picking some salient points up. And maybe in 5 years, it may refine where we get it. So we always caution patients that even though you are cleared, there's something called residual risk.
Yemi, again, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thank you so much for having me. My pleasure.